Thank you. My topic is office hysteroscopy, and office hysteroscopy is the minimally invasive gynecological procedure in which an endoscopic lens is inserted through the uterus cervix into endometrial cavity. In the endometrial cavity for diagnosis and treatment of intrauterine pathology, the tubal, ostia, endometrial canal, cervix, and vagina consists the procedure of office hysteroscopy. Hysteroscopy is considered a gold standard technique through which structural abnormalities and pathology of the uterus can be evaluated visually and treated. Hysteroscopy is a combined work from the Greek word hystero, that means uterus, and scopy, that means look. This is a picture of what happens during hysteroscopy. Hysteroscopy is outpatient procedure which can be done at hospital, community clinic, freestanding surgical center, and medical office for treatment of uterine cavity of cervical canal pathology under dietary visualization using hysteroscopic instruments. The history is long, but it was established in 1970. Hysteroscopy has proven to be both more sensitive and more specific for identifying uterine pathology when compared to dilation and curettage. Dilation and curettage is a blind technique associated with many limitations, such as high percentage of false negatives, difficulty to discriminate focal intrauterine lesions, incomplete suspicious tissue removal. Potential complications may include uterine perforation, bleeding, and infection. Hysteroscopy provides clear visualization of the uterine cavity, allows precise targeting of the lesion, treats specific uterine conditions, reducing the risk of damage to surrounding healthy tissue, and improving the effectiveness of the treatment. In health professionals with high level of surgical and clinical experience, office hysteroscopy is successful, safe, and well tolerated. The hysteroscopic procedures are categorized in 3 levels. Level 1, diagnostic hysteroscopy with target biopsy, removal of simple polyp, removal of intrauterine contraceptive device. Level 2, proximal fallopian tube cannulation. Yes. Minor Asherman syndrome, removal of pediculate fibroid type 0, large polyp. Level 3, division or resection of uterus septum, major Asherman syndrome, endometrial resection or ablation, resection of submucous fibroid type 1 or type 2, repeat of endometrial ablation or resection. The benefits of office hysteroscopy include abnormal uterine bleeding, lesions identified on image studies, streamline diagnosis and treatment planning, minimizing financial barriers, and avoiding unnecessary anesthesia when hysteroscopy is normal. The additional benefits include no operation room, no anesthesia premedication, no cervical canal dilation, a dramatic recession of the hysteroscope, smaller diameter telescopes, less complications, decreased cost, no recovery or fast recovery, no complication from cervical canal dilation. But hysteroscopy cannot assess deep myometrial disease like adenomyosis, tubal pathology, or extreme uterine contour. Additional procedures, laparoscopy or hysterosalpingography, are necessary. Limitations of office operative hysteroscopy depend on surgeon, patient, equipment, and uterus pathology. Surgeon-dependent limitations have relation with knowledge and skills. Patient-dependent. Patient is not relaxed as in general anesthesia. Observe, cooperate, communicate, and motivate. Pain is the main reason for failure office hysteroscopy. Pathology-dependent cervical os, mainly internal os. Cervical canal stenosis, mainly internal os. Equipment-dependent. Pain is the main reason for failure of office hysteroscopy. The causes of pain are introduction of the hysteroscope, the overdistension of the uterus, the direct stimulation of the uteromyometrium. The pain perception depends on age, medical conditions, gender, emotion support system. Risk factors for a painful office hysteroscopy: menopause, nulliparity, narrow cervical canal, dysmenorrhea, chronic pelvic pain, pre-existing diseases, limited tolerance, longer time of procedure. The procedure should be ended in 20 minutes, non-expert hysteroscopy. The indications include abnormal menstruation age above 40, abnormal menstruation not responsive to medical treatment age below 40, intermenstrual bleeding despite normal cervical smear, postcoital bleeding, abnormal premenopause or postmenopausal uterine bleeding, endometrial thickening or polyps, submucosal and some intramural fibroids. In the fibroid subclassification system, the type 0, that means pedunculated intracavitary, the type 1, that means less than 50 intramural, and type 2, more than 50 intramural, can be removed by office hysteroscopy. Here is a picture of fibroids, submucosal and intramural, polyps, intrauterine adhesion, uterine duct anomalies. Again, in this picture, we can see a normal uterine cavity, a septate uterine cavity, and a unicornate uterine cavity. In this picture, we can see retained intrauterine contraceptives, a cannulation of fallopian tube ostia, sterilization with Essure microinsert or Adiana insert. Other indications for office hysteroscopy include recurrent miscarriage, superficial adenomyosis, abnormal or equivocal findings on imaging, chronic excessive leukorrhea, endometrial hyperplasia, complication of pregnancy, evaluation of cesarean delivery scar defect or ismosile, persistent bleeding after termination of pregnancy, endometrial endocervical lesions, vaginoscopy, preoperative planning, post-operative or post-procedure follow-up, infertility. Here is a picture of gland-like openings, superficial adenomyosis, retained products of conception, contraindication to office hysteroscopy are viable intrauterine pregnancy, pyometra, active pelvic infection, cervicitis, surgeon inexperience. Spectrum of operative office hysteroscopic procedures are intrauterine biopsy, polypectomy, myomectomy, removal of a foreign body, vitroplasty, septum dissection or dysmorphic uterus, lesions of adhesion, fallopian tube cannulation, sterilization, adenomyosis. Equipment for diagnostic operative hysteroscopy include gold light source and light lead, video camera and monitoring, CO2 hysteroflator for gas digestion, irrigation, suction pump for fluid digestion, endoscopy card for hysteroscopy. This is a picture of gold light source and light lead, video camera and monitoring, fluid digestion systems and digestion media, connections for fluid digestion media, flow digestion pressure and vacuum power for operative hysteroscopy. Flow is 200 to 250 ml per minute. Digestion pressure is 75 to 110 millimeter high G. Vacuum power is 0.25 bar. Endoscopy card for hysteroscopy, image via video monitoring system. Instrumentation for office hysteroscopy is mechanical, electrosurgical, like probes, needles, loops, VersaPoint, resectoscope, and laser. Hysteroscope. The working length from the examiner eye to distal tip is 106 to 302 millimeter. Miniature hysteroscopes 2.7 mm with a 3 to 3 mm sheet diagnostic hysteroscopy, 5 mm for operative hysteroscopy. 4 oblique optical lenses, 0 degree, 12 degree, 25 degree, or 30 degree of lenses. Outer diameter, that means diameter of sheets, houses telescopic instruments, are 3, 3.1, 5, or 10. Smaller caliber endoscope simplifies examinations and permits practical, safe, efficient investigation of the uterine cavity. Optical lens, office hysteroscopy optical lens, 0 degree, 12, and 30 degree. Hysteroscopes are flexible, semi-rigid, and rigid hysteroscopes. Flexible hysteroscopes are used in diagnostic hysteroscopy or operative procedures in women with irregular shaped uterus. Semi-rigid hysteroscopes and dossier, the all-in-one direct visualization system for diagnostic and therapeutic procedures. Rigid hysteroscopes offer better imaging quality, fewer delayed procedures, quicker examination time, reduced cost. Here is a combo trophy scope with a diameter only 2.9 mm. Bipolar 5 mm resectoscopes perform resection without general anesthesia. Operative instrumentation. Operative hysteroscopes are used to remove endocervical or endometrial lesion or to perform endometrial ablation or resection. Some, but not all, operative hysteroscopes use electrosurgical cutting or mechanical aspiration of the tissue. The 3 types of operative hysteroscopes are operative sheet with the instrument inserted through channels or fixed to the sheet, electrosurgical resectoscope, hysteroscopic tissue retrieval system. Operative sheets, an endorsement of flexible, semi-rigid and rigid instruments, have been developed raised in diameter for 2 to 3 mm and are inserted through an operative channel to the sheet. These instruments include scissors, grasping forceps, biopsy forceps, and punctate electrodes. Rigid instruments may also be inserted through a channel or may be fixed to the end of the hysteroscope. Some systems have sheets which use suction to retrieve tissue fragments without removing hysteroscope. Rigid operative hysteroscopes. A rigid operative hysteroscope typically consists of 0 degree, 12 degree, 30 degree optical lens, an operative bridge that contains ports for hysteroscopic instruments, and an outer sheet with a 5.5 to 9 mm outer sheet. The outer sheet contains distation media, input and output channels that allow for continuous laminar flow and irrigation. The input and output channels also permit calculation of the distation medium fluid deficit either manually or automatically. The use of automated systems is preferred because they provide real-time fluid deficit calculations and can control the pressure at which the distation medium is styled. The output channel may also be used to evacuate intrauterine blood or particulate matter. This is a picture of rigid hysteroscope. Options for gynecological resectoscopes: size 16 Fry to 25 Fry, 7 Fry, handle mechanism passive active, sheeting system flow, continuous flow, rotating, electricity, monopolar, bipolar, electrode loop, roller ball, roller bar, knife electrode, optic 0 degree, 12 degree, 15 degree, and 30 degree. Monopolar resectoscopes have both inner and outer sheets. Inner sheets houses the optical lens and act as the input for the distation medium. Outer sheet is 7 to 10 mm and houses monopolar loop, which may extend it and retract it back into the sheet with a spring mechanism. Monopolar electrical current Electrolyte-free distillation medium like mannitol, glycerin, or sorbitol is required to prevent poor current dissipation. The 5.3 mm monopolar resectoscope has favorable results for removal of endometrial polyps and small, less than 3 centimeters type fibroma, type 1 or type 2 submucosal fibroma. This is a picture of resectoscopes, monopolar resectoscopes. Here is the difference of bipolar resectoscopes. The Gynec Versa Point Ethicon is similar to the design to monopolar resectoscopes. It has multiple operative tip attachment, including 0-degree and 90-degree loops for section and cutting, use bipolar electrocautery, use of isotonic distillation media like normal saline or lactate rigid solution, which lessens the risk of hyponatremia in cases of fluid overload. Bipolar resectoscopes. Morcellator. Hysteroscopic morcellator are safe, effective, and reduce operative time. Consists of a multi-port operative hysteroscope with an angle eyepiece and a morcellating handpiece insert. The morcellating attachments are composed of two hollow tubes positioning one with the other. The inner tube rotates or oscillates within the outer and can be seen through the outer tube's operating window located at the distal tip. The pathology is drawn into a cutting window via suction, removed by cutting action, and collected into the bag for histopathological examination. Morcellator. A picture of how morcellator acts. Hysteroscopic tissue retrieval system. Laser techniques. Several fiber optic lasers are available for gynecologic use, including potassium titanium argon and neodymium yttrium aluminum garnet lasers. They all have different wavelengths, though the potassium titanium phosphate and argon lasers have similar properties. Fiber optic lasers have the advantage that it can be transmitted through the fib inserted into the operating channel. This laser cannot block by fluids and can be easily directed to any area of the uterine cavity. The neodymium yttrium aluminum garnet laser is most commonly used, particularly for endometrial ablation, because it is attracted by purplish tissue and because it is destroyed tissue protein by coagulation in back, frontal, and lateral scattering. The depth of penetration is 4 to 5 millimeters, makes it suitable for the endometrial ablation, and laser it is infrared in infrared portion of the spectrum with 1064 nanometer wavelength, and it is typically absorbed by spirometry. These are useful for the endometrial ablation, adhesiolysis, and division of uterus spectrum. The main advantage using laser energy are avoidance of most of pain, low relapse rate, and high patient satisfaction compared with the energy bipolar procedure. The results don't seem to be related to the size or number of pathologies, and 12-month follow-up shows both better recurrence and compliance rates. Diode laser use, miniature size, cost effectiveness, relative simplicity of use, endometrial polyps, metroplasties, and mucosal myomas instead of bipolar needle, cleaner surgery without production of pulse, easier to inspect surgical planes, smaller thermal penetration, precise and safe surgery close to delicate structures, for location not easily accessible like tubal corner. Here is a comparison of energy modalities, monopolar, bipolar, and laser. The tissue effect is the same, cutting and coagulation in 3 modalities. Power setting in monopolar is 50 to 80 watt. Bipolar is 30 to 50 watt and laser is 15 watt. Thermal spread in monopolar, not well assessed because there are multi-variables. In bipolar is 2 to 6 millimeter and laser less than 1 millimeter. Maximum temperature is the same above 100 degrees of Celsius in 3 modalities. Laser techniques. Distation media for office hysteroscopy. Gas CO2 for diagnostic procedures only. Low viscosity fluid, normal saline, 5% dextrose, regular lactate, only with bipolar energy. 1.5% glycerin, 3% sorbitol, 5% mannitol, high viscosity fluid hyspon, only with monopolar energy. Local anesthesia and cervical dilation. Vasovagal reactions are caused by stimulation of the parasympathetic nervous system. The cervix receives parasympathetic nervation from the sacral nerves. Manipulation and dilation of the cervix can lead to stimulation of the parasympathetic nervous system, which causes hypotension and bradycardia and causes women to feel sick and faint. They may display clinical signs such as pallor, sweating, and reduced conscious state. Most women will recover rapidly if the procedure is stopped and instruments removed and they put the patient in supine or recovery position. Full fanning fluids and reassure will hasten recovery. In rare case, atropine may be need to be given. Here is a picture of nerves of female reproduction tract. Vaginoscopy technique. The vaginoscopy or non-touch technique is performed without speculum or tenaculum or without anesthesia. Significant decrease in operative pain, operative time was shorter. To perform the vaginoscopy technique, perform a bimanual pelvic examination with the patient in dorsal lithotomy position. Prepare the vaginal introitus with saline or povidone iodine without using a speculum. Introduce a rigid or semi-rigid narrow caliber less than 4 mm hysteroscope into the vaginal introitus. If use normal saline at a pressure of 150 millimeter of Ig. Close the labia minora manually if needed to contain the distending medium. Visualize the cervix and direct the hysteroscope through the cervical canal in the intrauterine cavity. This is a picture of correct passage of hysteroscope in the anteverted and retroverted uterus. Here is a picture of correct passage of hysteroscope during vaginoscopy, direction through the vagina and the os of exocervix. Here we can compare the traditional conventional hysteroscopy with non-touch hysteroscopy. In conventional hysteroscopy, insert speculum, grasp anterior lip of the cervix with tenaculum, sound cervical canal, delay cervix, place tip of hysteroscope against external os, start uterine distation, guide hysteroscope into uterine cavity, give local anesthesia if required. In non-touch or office hysteroscopy, place tip of hysteroscope against external os, start uterine distation, guide hysteroscope into uterine cavity, give local anesthetic if required. In the table above, we can see non-pharmacological methods for reducing pain in office hysteroscopy. These methods include vaginoscopy approach, mini hysteroscopes, reduced waiting time, music, calm environment meditation, experience of hysteroscope. In the table below, we can see levels of pain management during hysteroscopic procedures. Level 1, no medication or oral non-sedative medication. Level 2, local anesthetic, paracervical block. Level 3, conscious sedation, oral inhalation sedation, parenteral sedation. Level 4, regional anesthesia. Level 5, general anesthesia. Diagnostic hysteroscopy. without anesthesia in most patients, no adverse medication reactions, reduce procedure time cost, avoid a paracervical block, 3.5 millimeter hysteroscope produce less pain, 5 millimeter hysteroscope, a paracervical block is recommended. In a virtual reality intervention, a referred less pain compared with those receiving standard care during hysteroscopy. Operative hysteroscopy. In operative hysteroscopy, a paracervical block is performed or a hysteroscope 4 millimeter or larger is required. Operative hysteroscopy with intrauterine procedures, intravenous medication, and regional or general anesthesia required beyond the paracervical block. Limited toleration of local or intravenous anesthesia or other comorbidities, regional and general anesthesia is required. Patients with comorbidities may require intensive monitoring in operating room. Here is a picture of different methods of administration of local anesthetic for office hysteroscopy. We can give paracervical block, intracervical injection, cervical intrauterine instillation, or topical surface application. Paracervical local anesthetic injection with a dead syringe is the best method to reduce pain during office hysteroscopy. 2% lidocaine with 1 per 8,000 adrenaline in 2.2 to 4.4 ml at 2, 4, 8, 10 o'clock to avoid cervical vasculature. Approach to outpatient hysteroscopy. Patient counseling and selection. Exclude patients with cervical stenosis, limiting mobility and impeded positioning, comorbidities that require intensive monitoring, cannot tolerate the procedure with a local anesthetics. Provide anticipatory guidance about the degree and duration of discomfort. Verbally reassure the patient during the procedure. Procedure selection and approach. Choose procedures that are brief, less than 30 minutes. Perform diagnostic or minor operative procedures. Minimize on intraoperative pain. Minimize cervical dilation. Pretreat with a prostaglandin or combination with estrogen. Use a narrow caliber hysteroscope, less than 4 millimeter analgesia. Choose an anesthetic plan specific to the patient and procedure. Preoperative evaluation and preparation. Informed consent. Evaluation, medical history, obstetric and surgical history, medical comorbidities, medication and allergies. A complete pelvic and general examination is performed with particular attention to the size and mobility of the uterus and the pattern of the cervix. Pregnancy testing and cervical cultures are performed. Here is a picture of phase of a cycle, proliferate phase, secretory phase, mid-secretory, and atrophic endometrium. Office hysteroscopy is preferred to perform in early proliferate phase. Adequate cervical dilatation is an important step to hysteroscopy. Cervical dilation can be done mechanically at the time of procedures associated with risk of pain, uterine perforation, false tract creation, or done preoperatively with cervical ripening agents. Isoprostol 200 to 400 microgram orally or vaginal 24 to 48 hours prior to hysteroscopy. Dinoprostol may require additional mechanical dilation of the cervix. Mechanical dilation with laminaris is effective, but the procedure needs additional visits before the surgery. Vaginal estrogen, 25 microgram vaginal estrogen 14 days prior to hysteroscopy, along with 400 to 1,100 microgram vaginal misoprostol 12 hours prior to the procedure, is the dilation and reduce the pain. Eating primrose oil facilitates cervical ripping and dilation in both pre- and post-menopausal patients. Two soft gels, each 500 milligram, placed into the posterior vaginal fornix 6 to 8 hours before operative hysteroscopy. It is easy to use, available, inexpensive, with no serious sequel, but study results have not been replicated. When dilation of the cervix is difficult, a flexible hysteroscope may be passed more easily than a rigid dilator. For women who fail these measures, intracervical injection of dilute vasopressin 4 units per 80 ml normal saline has been reported to facilitate cervical dilation. Although it is generally well tolerated, vasopressin injection may be performed with caution since it is vascular injection or has been associated with profound hypertension, bradycardia, and intraoperative mortality. If a small dilator cannot be easily inserted, hysteroscopy can be performed under ultrasound guidance to ensure the correct passage of the dilator into the endometrial cavity and make sure a false passage is not created. Uterine position. Extreme uterine retroversion or underversion is congenital or from pelvic adhesion. Traction of the anterior lip of the cervix will straighten the uterine axis. We use flexible hysteroscope and we use transabdominal ultrasound to reduce uterine perforation. If we have difficult uterine distension, we can imagine obstruction in the uterine cavity or false tract. Position of the patient. Patient in dorsal lithotomy position. Here is a diagram in operating theater. CAD-CAM or stir-ups. Care must be given to the nervus of the patient. Modify lithotomy position with stir-ups. Technique of operative hysteroscopy. A thorough history and physical examination should be performed. Best performed in the proliferative phase of the menstrual cycle. Post-operative infection rates are low, and it is not recommended the routine of use prophylactic antibiotics. When significant resections, myomectomy, spectrum resection, or lesions of adhesion, or more involved procedures are performed, the use of antibiotics is recommended. Appropriate antibiotics include cephalosporin or doxycycline. Equinolone or clindamycin plus zidamycin may be used in cases of penicillin anaphylaxis. Technique of operative hysteroscopy. Informed concept is obtained. Patient is transferred to the operating room, dorsal lithotomy position, 10% povidone iodine vaginal and perineum preparation, adequate anesthesia it is necessary. Surgery may proceed. Visualization of the cervix, progressive dilation to the required diameter with cervical dilators, hysteroscopic equipment set up and functional. The flow of distension medium is started and flashed through hysteroscope. Passes hysteroscope through cervical canal into uterine cavity, viewing monitoring. Distension medium expands the intrauterine space. Continuous flow improves visualization and note intrauterine landmarks. At the end of the procedure, the distension medium is evacuated, all instruments are removed. Complications of office hysteroscopy, early and late. Early, uterine perforation, fluid overload, hemorrhage, gas embolism, cervical trauma, endocervical balloon. Late, intrauterine adhesion, uterine rupture after mitroplasty, hematometer after endometrial ablation, post-ablation sterilization after endometrial ablation, pregnancy after endometrial ablation, cancer after endometrial ablation. Safe procedure, complications in 0.95 to 3% of cases, hemorrhage 2.4%, uterine perforation 1.5%, cervical resection 1 to 11%, excessive fluid absorption without resulting hyponatremia, rare complication. Uterine perforation, most frequent complication, possibly for corporeal laparoscopy, incident 0.7 to 3% after accessiolysis, myomectomy, septum resection, or during section of the hysteroscope. Diagnosis, direct visualization, and expected rapid increase in the fluid deficit, uncontrolled hemorrhagic hemorrhage, hemodynamic instability, uterine perforation, monitoring vital signs, uterine output hematocrit, perforation through the posterior or lateral uterus or by sharp electrocotic instruments should prompt laparoscopy because the potential injury of the pelvic visceral vasculature. A hystoscopy should be performed to evaluate for bladder injury of anterior perforation. Fluid overload electrolytic balance, incidence 0 to 2 to 0.70%. Potential serious complication after myomectomy, uterine septum resection, extensive lysis of saturation, prolonged operative time, increase the risk of significant fluid overload and hyponatremia, especially when hypotonic distension media is used. Intrauterine pressure should be kept below the mean arterial pressures. Management of fluid balance, less than 1 liter. Surgery is continued, well tolerated healthy patient. 1 or 2 liter, surgery complete. Mild hyponatremia, 20 to 40 furosemide intravenous must be given. Management uterine output electrolytes. Above 2 liters, stop surgery. Severe hyponatremia, fluid overload, monitoring uterine output and electrolytes. Abrupt changes in the serum sodium levels can lead to altered mental status and progress to seizures, coma, and even death. If intraoperative or postoperative sodium levels fall below 125 milliequivalent per liter, the patient should be transferred to acute or critical care settings. Intravenous 3% sodium chloride may be given at a rate 1 to 1.5 milliequivalent per liter per hour, and furosemide should be used to achieve the appropriate amount of diuresis. Fluid overload resulting in pulmonary edema can occur in cases with excessive intravasation of isotonic fluids. The problem may be compounded by not decreasing the rate of intravenous fluid administration and compensate for hysteroscopic absorption of distension media. The uptake of relatively small volumes of dextran can lead to significant vascular volume expansion because of fluid osmotic properties. Here is a picture of excessive fluid absorption leads to cerebral and pulmonary edema. Hemorrhage during and after of hysteroscopy. The surgeon should be first ensure that the noted bleeding is not a result of uterine perforation. Mild bleeding is typically self-limited and generally does not require derivation. If brisk bleeding occurs, electrocautery may be used to coagulate small vessels. If this conservative approach fails to control heavy bleeding, or if there is bleeding from larger vessels, a Foley catheter or intrauterine balloon can be inserted into the cavity and inflate to indubinate the hemorrhage. A Foley catheter may be connected to connection back to monitor blood loss. Rare complication, postoperative intrauterine adhesion formation, uterine rupture in subsequent pregnancies. A Foley passage with cervix may be created by overzealous or misdirected hysteroscopic section or inadequate cervical dilation. Poor placement or vigorous manipulation of the tenaculum may result in cervical laceration. Bleeding laceration of the cervix are easily repaired with delayed absorbable polyfilament surgery. Postoperative endometritis will be treated with broad-spectrum antibiotics in hospital settings if necessary. Gaseous embolism is extremely rare. Patients are able to go home at the same day and resume a regular diet as tolerated. For patients undergoing extreme resection, crabbing or vaginal spotting for 1 or 2 weeks following the procedure is normal. Most patients experience postoperative crabbing or light bleeding, and some complain of vaginal discomfort. Carbon dioxide distension can cause shoulder pain, but this typically resolves within 15 minutes. Acetaminophen or non-steroid anti-inflammatory drugs are usually adequate for postoperative pain control. In women desiring immediate fertility after polypectomy, pregnancy may be attempting the following menstrual cycle. If a metroplasty or adhesiolysis is performed or a myomectomy results in the removal of fibroid with a C-type intramural component, pregnancy should be delayed for 3 months. Contraception should be considered. The range new intrauterine adhesion formation after septoplasty 88%, adhesiolysis 76% is higher than of myomectomy 40% and polypectomy 0%. Vaginal birth is an acceptable mode of delivery following hysteroscopy myomectomy of type 0 or 1 fibroids. Post-operative cause, the patient is typically seen for a post-operative visit 2 to 4 weeks following the procedure. A repeat anatomical survey, sinus infusions on histogram or diagnostic hysteroscopy may be warranted in some cases to ensure the lack of adhesion formation or to complete to ensure that we have complete atoll fibroma or septum. Take-home message: outpatient or office hysteroscopy is a safe and well-tolerated procedure that's performed both in pain and operative indication of uterine pathology. This procedure needs high level of surgical and clinical experience as well as correct diagnosis of uterus pathology before undertaking an operative hysteroscopy. In expert hands, this procedure lasts less than 20 minutes, can be performed at office without anesthesia or premedication, without cervical canal dilation, with miniatures hysteroscopes. The benefit of this procedure are less complication or recovery is fast recovery, no complication, no cervical canal dilation, feasible, decreased cost. Hysteroscopy is best performed during the early proliferative phase of menstrual cycle. Anesthetic options for women undergoing hysteroscopy are highly varied and range from nothing or till to general anesthesia. Bipolar electrocautery allows the use of isotonic distation media. Electrolyte-free distation medium is required to prevent current dissipation on a monopolar electrical current. Traditional resectoscopic surgery should be reserved for more complex cases such as endometrial ablation or specific conditions like myomas with a diameter upper to 1.5 centimeters, broad base septa or large polyps. The operator's argument significantly impacts not only the success of procedure, but also the management of potential complication. The world of outpatient hysteroscopy offers an array of innovative procedures and tools, among which the new high-cost use technologies. While these technologies can significantly enhance the precision and efficacy of hysteroscopic procedures, will limit the cost factor associated with them cannot be ignored. Therefore, a comprehensive understanding of this cost and the potential impact on the healthcare system and the patient is crucial. The balance between adopting new technologies and ensuring cost effectiveness should remain a central theme in the evolution of outpatient hysteroscopy. Thank you.